I felt a deep-seated commitment to do it because I could do it. Like I went to Yale. I didn't really know what was going on there. I went there. It was super hard, but at no point did I think I wasn't going to make it. I'm like, I'm making it. Failure is not an option here. And of all my training places of higher education, that was the one. It was totally not that pleasant. I didn't feel pressure externally. It was more like this internal pressure, not just to get through, but to do well, so I can have some choices. I don't get super up. I don't get super down. It's sort of like there's a job to be done. You stay focused and keep to the task. Yale was, listen, man, that was no joke. I was a biochem major. It was not fun. You're just a product of each step, and I didn't have a lot of exposure, so I just paid attention. I have the reputation that I have is that I always tell people I'm just a guy. Like, I've done a lot of surgeries and I know some stuff. I do not know everything, and there's something to be learned in every clinical episode. I enjoy clinics. Like, I enjoy people. I don't enjoy it when they're not doing well, but you learn from it.
As a kid growing up, we always have that internal drive. Or when do you start discovering that? All right, everyone, welcome to another episode of the Myokinetix podcast. Today we have Dr. Ryan Williams of HSS. He is the head surgeon of the Brooklyn Nets and also the New York Liberty and the Red Bull as well. So, Dr. Williams, welcome to the show.
Thank you. Happy to be here.
So I'm happy you're able to squeeze us in of your busy schedule. So when we get started, let's talk about your background, your upbringing. Like, what made you become a surgeon?
Well, listen, I grew up not very well. We were, more poor, but it wasn't like a big money situation. So I always looked at potential career paths. Medicine, I was good at science throughout kind of middle and high school, actually really good. And I didn't know what business was, so I figured, medicine, that's one. There's steps to it. I can keep knocking out the steps and get through it. So I didn't really have any real preconception about what I wanted to do in medicine. It was more so I just wanted to be a doctor. It was a means of kind of bettering my economic plight. And then once I went to medical school at Stanford, I just happened to fall into a lab. It was an orthopedic research lab. I was a science major in college. I played football in high school. I played a little bit in college. And had a little bit of a predisposition towards orthopedics. I didn't really know what an orthopedic surgeon did day-to-day, really, because there's not a lot of doctors in my family. So when I got there, I just sort of fell into orthopedics from a research standpoint. So I published quite a few papers early in medical school, and it just became sort of like a natural progression of things that I had a basic science background, quite frankly, in cartilage, which is one of the things I do a lot of. And you get to know mentors and you see how happy they are and the lifestyle they have. And quite frankly, you look at some of the other ones. I thought about neurosurgery for a hot minute until I hung out with the neurosurgeons for a couple of years. I sort of changed my mind. But at the end of the day, the way I like to think about it is I was fine in sports. Never really thought of that as a long-term career goal, but you start getting to know people like my mentors, Russ Warren played a big role in my life, Dave Alchek, Tom Wickowitz, Steve O'Brien. You get a peek into what they did, and it became super exciting, and ultimately that's why I decided to be a sports medicine physician.
So I want to dive into your background a little bit. So obviously you say you grew up without a lot of resources. Were you one of the first doctors in your family?
Oh, totally first doctor.
So I'm the first one in my family as well. I moved here from Thailand, so we didn't have much, but nothing changed the family narrative like someone pursuing a higher degree. So what was that like, the pressure to do that? Was there a lot of pressure on you to lead the family, to change the narrative?
Listen, I'm sure there was. I didn't conceive of it that way. It's pretty funny. No one ever really asked me that question like that. I felt a deep-seated commitment to do it because I could do it. Like I went to Yale. I didn't really know what was going on there. I went there. It was super hard, but at no point did I think I wasn't going to make it. I'm like, I'm making it. Failure is not an option here. And of all my training places of higher education, that was the one. It was totally not that pleasant. But once I finished, I was like, well, if I can do that and master it, then it's pretty much I can do anything. And that really sort of changed the narrative. So I didn't feel pressure externally. It was more like this internal pressure, not just to get through, but to do well, so I could have some choices. So yeah, but that was really a big, huge change for us.
Were you always like that as a kid growing up? Were you always have that internal drive, or when do you start like discovering that?
My grandmother, rest in peace, she used to get mad at my mother because she says, your child is way too mannish. Like you talk to him like he's an adult. That's not appropriate. My mother says, well, he converses like one. It's like, what am I supposed to dumb him down? And I remember those things. I mean, in retrospect. However, I don't know, man. Like, I don't get super up. I don't get super down. It's sort of like there's a job to be done. You stay focused and keep to the task. Yale was, listen, man, that was no joke. I was a biochem major. It was not fun. It was. I should have been like a history major. I would have had more fun. Like Brett Kavanaugh, Supreme Court justice, who was my classmate. But you're just a product of each step, and I didn't have a lot of exposure, so I just paid attention. And I was fortunate enough to have gained entry into some of these kind of ivory tower institutions, but I never really kind of got into it like, oh, I've arrived, I've made it. To me, you're eternally a student. I'm still a student. And the moment you start thinking you've sort of arrived is when you stop being that way. I think it's one of the reasons that I have the reputation that I have is that I always tell people I'm just a guy. Like, I've done a lot of surgeries and I know some stuff. I do not know everything, and there's something to be learned in every clinical episode. I enjoy clinic. Like, I enjoy people. I enjoy I don't enjoy when they're not doing well, but you learn from it.
Yeah.
So fortunately each year that number of not doing well has gotten smaller and smaller. So it's really almost a surprise to me when someone's not doing well.
Yeah.
Oh, okay. I better stop. I gotta pay attention.
So how did you navigate, again, applying to like Ivy League school, then go to Stanford Medical? Did you have early mentor to guide you through that? The reason I'm asking is because we do have tons of athletes that come to us for PT, and then they fell in love with the rehab process that they start looking to medicine. But then like most athletes, if they come from inner city, they don't have that much guidance, right? So like, how do you figure out all those steps of like application and all that? And if you're the first one to do it, especially, if your first undergrad is in Yale, which is extremely competitive, like how did you kind of find your way there?
Well, so I went to a school in LA. It's actually in the inner city of LA, Loyola High School, which is a Jesuit all-boys school. And that was probably the seminal decision back in 1979, right? Is that right? Yeah. So that was not popular. An all-boys school. Everyone's like, what's wrong with you?
Yeah.
With the obvious, sort of implications in and around that. I had seen it differently. It was very simple. It's like, okay, I was raised Catholic. It's a Catholic school, sort of the values are there. What people don't know about Jesuit schools is that they tend to be underpriced for private schools. So, I have a 24 and a 26-year-old now. So I remember what I was paying for them to go. They went to private school. Loyola was about 10% of what a typical private school was. So it was accessible, with the I remember going to school with the $25 in an envelope every month to pay the tuition. It was pretty cheap. I want to say maybe it was like $300 a year.
Oh, wow.
It was crazy cheap. I mean, it was 1979. So, but the experience I had there was I didn't understand in real time what I was doing. So I was doing well in school. I knew you wanted to do well in school and take rigorous courses. But at the end, the Jesuits really took care of me. They kind of opened my eyes to what could be accessible to me. I had no idea. Like my reach school as a senior was Stanford, which everybody would say, of course, that's a reach school.
Mhm.
However, the other schools were like USC, UC Irvine. It was like all the UCs, and none outside of California.
Mhm.
So they basically said, all right, leave Stanford here, move the other ones all down. You know, you're third in your class, and you have blah blah whatever the SAT was at the time, which was good. And I was like, oh, I didn't know what that means. So I owe them a lot of sort of props there, because they really did support me in a way that I would not have if I hadn't been at a place like that. I mean, I'm sure it would turn out fine,
Mhm.
but it definitely would not have been Ivy League. So the Ivy League thing, and just to speak to all the kids now who are in that swirl, I went through it with my kids. It is different now. I'm not saying that, oh, it's just sort of easy happenstance into it. Obviously, everybody plans, but for me at that time, they just allowed me to sort of see what could be,
Mhm.
and I had a very sort of like magical college application process, which is not the way I think it goes.
Mhm. Yeah, you know what I love about, and I've been following for a long, long time, your work, your research, and we have been fortunate enough to work with some of the patients that come from you. And what I love the most is you always seem like an individual who stay curious all the time, right? And I think that just opened a lot of good conversations. So, based on your upbringing, how does that lead into how you practice now?
Yeah, well, I've gone through my evolutions as a physician, from not knowing things and then coming to HSS, and HSS was a tough training program, not physically tough, but mentally. There's a lot of navigating. Medicine is part science, part social. So I always enjoy the social part. Listen. I think it's a privilege to take care of people. I really do. I mean, uh, you're not making money like hedge fund guys or PE guys, but you have what I would say a huge impact on people's lives, typically in orthopedics in a way that isn't necessarily super morbid or mortal. I mean, you have to walk to go to work, right? So we aren't talking about these seminal life and death issues, but you are talking about functional issues that have a big impact on people. So, listen, you have a frozen shoulder, you can't sleep. You don't know how to fix that,
Mhm.
right? You need help. You need somebody to usher you through the process. So, for me, just sort of keeping your wits about you and saying, and I literally say this to every patient, okay, if I was this patient, what would I need to hear right now to A, calm my nerves, B, inform me, and C, allow me to make the most, educated decision I can make. So I try to look at it as an educational experience.
Mhm.
And for me, so for me, I changed my model a few years ago from a practice standpoint. So I work with HSS as opposed to before, which is more of a private practice model. But the beautiful thing about that is the hospital gave me more clinical resources, so I have more breadth,
Mhm.
more time, more availability mentally to sort of dig into people's issues. It's been phenomenally great for me,
Mhm.
and I think if you were to ask the patients, they feel the same way. But what we should get into a little bit is where did the approach come from? And so my approach to patients comes from that social piece, but also being a doctor for these pro teams. I mean, it's pressure, not like a pressure like, am I going to find the money to pay this bill? But it's more like, when an athlete gets injured, who's kind of a high value elite athlete, there's always other interests involved. And there's always a crunched timeline, always. So you alluded to it earlier. Yeah. So I tell people, all right, when you have surgery with me, do not go on the internet, because what you're going to read is not what we do. We're going to try to maintain muscle tone. We're going to try to restore gait as quick as possible. We're going to try to get our range of motion back as quick as possible. We're going to get rid of the effusion as quick as possible. So the older I get, the less crutches, the less bracing, the more normative behavior with regards to restoring normal knee kinematics. So I think that's what has really burnished me, and you learn a lot from patients. Like, I was taught all the things you were mentioning, like, oh, you do a Carlos procedure on the crutches for 8 weeks. Well, I used to do that, and it was a disaster. I mean, you'll make a 6-month recovery into a year just because of the the drastic quad and lower extremity strength index loss you get. So over the years, you learn from the patients who don't listen to you, and you come back at 6 weeks. You're like, "Where's the brace? Oh, I got rid of it at 2 weeks. Oh, where's the crutches? Oh, well, and he felt fine, so I just walked on it." You know what I mean? Like you hear that for the 25th time, and you're like, "Oh, maybe we're onto something." So I pulled that switch, pulled that trigger on that for most of my lower extremity surgeries in the early 2000s, and I always remember getting up at the podium and talking about it, and someone would say, "Well, you need to do a study on that because I don't believe you." And I'd say, like, "Well, you don't need to believe me. I'm not here to convince you. I'm just telling you what I do." And that has worked out really, really well, just from a patient recovery standpoint. I think my patients, in general, probably do progress through their PT a little bit more quickly than I would say, respectfully to my colleagues, traditional pathway. It doesn't mean it's better. It's just for me and the patients I have, it fits. They're all very motivated, hyper-athletic individuals who are mentally affected by not being available, and I understand that. And so getting someone back on their feet and walking Natty, like 6 weeks after an ACL, and they're looking like they could go play like little soccer or basketball is hugely empowering, because that's their biggest fear, right? They come in, you have this torn ACL, and they're all thinking the same thing, like, am I ever going to play again? Will I be the same? Is this surgery going to hurt? How long am I going to be? I mean, it's all these like anxiety provoking things. So I'll lead with my expectation that 6 weeks you walk in here with no brace and that you look pretty normal. Like that's a shocking statement to them. It's not what they have been reading, and it's not what they've been thinking. So now I have their attention, right?
Yeah.
And then I just sort of walk them through. And again, it's not that it's, I don't call the program aggressive. It's permissive. You're a therapist. If someone doesn't have quad control in 2 weeks, you're not going to take them off crutches.
No.
Right. So, and nor do I demand that. But the point is, if you start letting people hit the BFR at day 3 or 4, and you have them move right away, and then at the end of the first week, they're like, "Hey, 50% weight bearing." I mean, they want to do it. So if they do it and there's no real negative feedback or minimal negative feedback from that, then you're typically off to the races.
Yeah.
And then last thing I'll say is, the PT floor is a competition, right? People are on the floor and they're looking around and they're like, "Oh, what did he have? Or what did she have? And oh, when was the surgery?" And they start doing some comparison shopping. So it's very positive and brings the right energy when you feel like, "Oh wow, I'm at the front end of this curve," and it allows me to hold their attention longer through the rehab.
Yeah. So a couple things. I every time we get a patient from you, I feel like their buy-in is so high. So how are you able to cultivate that? It's almost like you're a culture you created per se when it comes to your patient.
Oh, you think it's a
Could be.
Yeah, I try not to get too deep into reputation and largesse, honestly. Every single family group who comes to the office, you have to take a beat and say, "This may be my 8th ACL that I'm seeing today, but this is the first time they're hearing it." And that expression of care and sort of informational exchange is important to developing that bond. So, and I don't take that for granted. And I try to convey that. It's something that you can't convey. Like I've thought a million times, like, "Oh, I should have a YouTube channel and just tell people like, "Oh, go look at the channel." That's
not the same.
That's not how we do it, right?
Yeah.
I mean, if you want like a review, yeah, maybe then, but you can't. I've just know some colleagues, I won't name names, who used to do that. They say, "Oh yeah, you have this condition. I'm going to leave and you're going to watch this video and then come back." That's just not how I do it. I just never thought like that. That's not going to seal the deal for you.
Yeah.
And I really need them because listen, not every surgery goes great. Things happen. And so if they feel like you're all in and you've been paying attention, most patients are very forgiving in that way. And again, when you're in the business of treating human beings, you have to build that in. There needs to be a trust with us. So fortunately, as I mentioned to you earlier, we don't have a lot of issues, fortunately, but sometimes things happen. And for me, it's just a way to ensure that you feel like I know what is going on with you, that I understand your problem, and that I have a plan for if everything goes right or if something goes a little sideways, that I'm dialed in and that we're going to get you through it. So I think that's why the buy-in.
Yeah, I love the way you say about the permissive approach, just because when we look at any injury, it's all traumatic, right? So, there's some sort of PTSD a little bit there. So to be able to get them back on the course sooner than later, I think we just kind of lessen that, I guess, that gap of them overthinking whether they can do it sooner or later. And I love that approach a lot, just because we came a long way, especially with ACL, when they used to like just cast people.
That was, it's funny you bring that up. That's something I usually talk about in the office with these ACLs. Someone will come back in 6 weeks and they're like, oh, it still hurts a little bit, or I have a little bit of swelling. Is that normal? And I'm like, when I got to HSS, it was 6 to 8 weeks in a cast, toe touch weight bearing, no motion. So you just were getting out of a cast at 6 weeks. And it was like largely a much different experience, and not in the positive.
Yeah.
To what we see now. So but patients don't have that perspective. They just know that they've sensed something's wrong, and so they feel a little anxious about it. But long way from that in terms of, progressing people. And again, the big change between 1 year recovery from ACL and now what is sort of thought of as the standard of 6 months is largely because of ditching that particular protocol with regards to the casting piece. So that's why typically most of my surgeries, it's no more than 1 week toe touch weight bearing, immediate motion. I'm a big fan of BFR. We can get in that a little bit. Just restoring normal knee kinematics, which specifically means full extension, flexion of at least 130 degrees, minimal effusion, good patellar mobility, which is really key after any surgery. And obviously, if there's a cartilage reconstruction, making sure that works, or if it's an ACL or something like that, to be stable. I mean, it's not super complicated, but if you use those guiding principles and you're done with all that by 6 weeks, if you think about it, there's not a whole lot else to do. Build muscle. So that's less. You and your staff become more guiders as opposed to like practically making people do stuff. I say this all the time, that physical therapy is not training. That you need to train, because if you really want to hit that mark as close to 6 months as possible, you need a certain degree of aerobic conditioning, neuromuscular return, as well as the psychological. So you'll feel the psychological confidence if you feel fit, and if you feel fit, then you're physically able to execute these things. So everyone's like, well, should I go to physical therapy 3 times a week? I'm like, no, you should go to physical therapy maybe once a week and take your ass to the gym.
Yeah.
Right. Because that's where the work gets done. And again, that process has been burnished in me because I'm around these pro athletes all the time. There's an injury. Most of the time, the injury is not surgery, but sometimes it is. And then there's a recovery that's directed by rehab. And then when rehab and medicine is like, oh, the patient's cleared, then they go to strength and conditioning, right? Where they kick their ass. So, most people, normal people, don't have access to that pathway. They have access to the doctor. They have access to the therapist to a degree. But there's a big gap between kind of functional return and clearance, which it's hard to explain that to people. They kind of look at you a little bit with these big eyes, but they see it. So I try to speak in objective terms, regardless of the surgery that you're going to have. I like you to get within 10% of normal of your assumed normal knee with regards to whatever measure you want to use. Isokinetic testing, lower extremity strength index. I don't really care, but just some objective number that we all can point to. I had a very famous soccer player from Brazil come in, and they had a 50% strength deficit at like 5 months, and was asking me when I thought they'd be able to play. I'm like, I'm not even going to talk to you about playing. This number's got to be like double. So it's a nice thing for you to be able to fall back on, because the numbers it's math.
Yep.
You can't fudge it. So it's allowed me to be a better position with regards to preventing re-injury and allowing people to return to their sport safely.
What I love of every time I come in here, I'm always impressed with HSS approach and everything else, just because it's almost seemed like this facility is able to identify the gap in medicine and always trying to close that gap every single time. Like the reason my clinic exists was, I was a strength coach before, but then when I became a PT, it was like, well, we no longer load people. That's weird because I know what the end looked like, right? So, the way I describe my facility is almost like we're doing performance rehab where like at the end of the day, I know what the end's gonna look like. So let's get through there sooner. And having like a strength coach in-house and all of that stuff, that just able to get us to transition and get the patient to actually aim up, which is, I think, is the key where we kind of miss in medicine a little bit because you mentioned correctly because most hyperactive people are very competitive, right? You're pretty competitive yourself. So if someone's ahead of you a little bit, you're going to want to close that gap. So having that environment is huge where, obviously being in here and everything else, how do you guys, like, what's your process when you see something that is cool and new and you're like, oh, you know what, I kind of want to try that out. And how do you go ahead and trust your judgment on what used to work in the past, but we could do something because there's risk involved, right? Because every time we try something new. So like, how do you walk that through, especially, with new procedure or just explain to the patient, like, hey, this could be this way, but historically it, doesn't really work before.
Well, I think patients really do trust you.
Mm-hmm.
And what I mean by that is by the time they've selected you as their physician, in many ways, it is a little cultish, right?
Mm-hmm.
They buy in. So, but for me, new technology, I think I've obviously been really involved at the front end of a lot of things, but it requires some healthy skepticism and an understanding of the biology of what you're doing because you are a surgeon. Right?
Mm-hmm.
I always tell people you have to understand the biology of your repair. Does something need to grow? Does something need to incorporate? Does something need to mature
Mm-hmm.
as it relates to load and the PT? So I think I've never had trouble, laying out a logic or a rationale to people for some of the newer things. Like for example, like osteochondral allografts. I did the first osteochondral allograft, I believe, in New York in 98 or 99. I can't remember. I know it was the first one. And think about that person, right? It was like, hey, there's this new implant kind of available. There's some research out on it from a couple of centers across the U.S., not that many. You've had 8 surgeries. I'm not sure how this is going to work, but I think it's a good option given you're young and we like to preserve the biology of the knee. And you walk through it. If you hear yourself talk, you're like, yeah, this makes sense, right?
Mm-hmm.
So again, it goes back to what I told you earlier, which is I try to put myself into the patient's shoes and say, okay, if I was a patient, what do I need to know about this? And so that informs my description or the pre-talk, just the discussion. So my office visits, anyone who's been through knows it's not paternal. It's like I try to make it like informative, like office hours with a teacher, right? No pressure. Want to make sure you understand the material. And in most cases, there's no real pressure around like booking.
Mm-hmm.
So one of the things you never hear me say is like, oh, you need to book this,
Mm-hmm.
right? It's like, all right, well, go home, think about what we talked about, talk to your stakeholders, let me know, I'm here.
Mm-hmm.
If you want to do it, it's all good. And that's an art, quite frankly. No one wants to be sold. They want to be informed. They want to take their time, and everyone's process. And there's a big range, right? Some people are like, yes, let's do it tomorrow. Some people are like, well, I need to think about it. I want to talk, 5 or 6 times, which is fine. But my point is, like, I don't try to insert myself or to change that individual person's process with regards to these decisions, because they're big decisions. And again, I never want to come across as pressuring someone, unless there really is some emergent nature around it.
Mm-hmm.
Fortunately for me, but my practice doesn't have a ton of that.
Yeah. So based on the resources and the access to information that you have, what do you think the future of ACL rehab is going to be? ACL injuries?
Oh man, we could have a whole nother couple of hours on that one. Well, let's just we talked about it, but let's just talk about it overtly. There've already been massive gains and changes in ACL surgery since 1992, primarily in and around rehab. right? 1 year to 6 months, that's a big change, right? 6 months is a manageable chunk of time for most people. A year sounds terrible, right? Even though in some cases it may take a year. So, grafts and you use allograft, patellar tendon, quad tendon, I do them all. I do over 100, 110 ACLs a year. So I feel pretty comfortable with the procedure. I don't know that the procedure itself is going to change a whole lot because you're trying to restore the anatomy of the ACL. So that requires that you go where the ACL that got torn was, right? So there are different ways to do that, which is largely surgeon based. But for the patients, I think, will we be able to, repair an ACL? I have my thoughts about that, but that's an area of interest. Using different materials as opposed to someone's tissue or an ACL, collagen strips, biomaterials that may mimic the early scaffold of an ACL. That's I would say that's probably certainly on the horizon. But I don't see the actual procedure itself seminally changing. To get into the rehab piece, I think based on my experience and the experience of the Europeans, bracing will probably start to go away. I'm this close to not using a brace after surgery and just using crutches for a week or two till they get quad control. In my how many years? It's 26 years, 27 years in practice. I haven't had anybody tear their ACL during rehab, not one. That's a lot of ACL. So I'm like, well, why am I bracing? Like, is it because of the brace? Because the brace can lead to, in some rare occasions, some stiffness in the front. Maybe they have problems with extension, what have you. No one likes the brace. Yeah. So that's one I'm kind of toying around in my mind. But in terms of big, huge changes, BFR, blood flow restriction, big change, which I've implemented with the help of you and your colleagues in and around the network. I think that's a big, big important thing in terms of, again, preserving quad mass, quad bulk, and the affected leg. That's been a game changer in many, many ways. Because I think there's a muscle pump you get with that.
Oh, it's the best.
Oh my God, you feel this way. Yeah. It's uncomfortable, but it's also very enabling and empowering for patients. So, I think there is a 6-month ligament maturation process. If we could somehow speed that process externally, ultrasound, laser, stem cells. I don't know. I'm just totally throwing it out there. My point is, you're sort of hamstrung a little bit by that maturation process that takes 6 months for the graft to mature. So you can get all the patient kind of back and buffed up and looking great at 3 months, which quite frankly most of them do. But if the ligament's still going through that 6-month process, it's hard to sort of speed that up. So as we've alluded to, and I'll just say it overtly, I've tried to make the experience better. Get them feeling and behaving like an athlete as early as possible, then you'll have an athlete. Yep. Right? It's not like you can tell them don't be an athlete for 6 months and then in 6 months it's like, all right, now you're fine to go. And you want them to have had some of the feels, right? So I do let them do some, pivoting is a strong word, but some directional change at 4 or 5 months, sub-maximal effort, just so they get used to that rotation again. And that's probably aggressive, but at the end of the day, it seems to work because all my sports are pivoting, directional change, acceleration, deceleration sports. And the big ones are soccer, obviously, basketball, lacrosse, and then in my older set, downhill skiing, pickleball, tennis, stuff like that. So you have to introduce that rotational stuff in. If you're going to allow someone to do that, not long after you clear them, after the 6 months.
Yeah, no, I mean, new research from like the EPATs too, like talking about accelerated graft healing. That's been a huge thing. I think EMTT is now coming out more with like just even like helping with like bone recovery, especially drilling into the bone. So that's something we've been keeping an eye on. But so far the EPAT's been a huge help for us when it comes to like getting the pain away, getting patella moving. But the graft maturity, that's a huge part. I do agree with you when it comes to teaching. we have this thing in the clinic where you got to earn everything that you do. And once you've earned certain thing, we're like, then you have full trust in your body and you have a full trust of the team that you're able to do it, right? And part of, I think our job in medicine is always to see the potential of the patient that they have lost or they could not see for themselves. Because if you can see a better future for them, then you can kind of anchor that for them, right? So that way they can kind of follow it through. I do agree with you when it comes to teaching, pivoting way later, because at the end of the day, all athletic motion is all triplanar, right? You can't just especially with soccer, lacrosse, and all of that stuff. So being able to instill that with him as early as possible, like, hey, here's what the rotation is going to be at the trunks, at the hip, and keeping knee stability. Because at the end of the day, I the way I look at it is like the knee is like the middle child. Is get blamed for everything, right? The ankle stiff or the hip is stiff, is go to the knee. Now, with what you're saying in advance and your approach, how is that gonna? What is that looking like for you when it comes to your impact scale? Because you mentioned this earlier, right? Because you see like you're making more impact more than hedge fund guys, rather than just helping people retiring early. If anything, you're helping them, living a meaningful life. So what does that mean for you when it comes to what's your life going to be by the end of your career? What do you envision by the time you hang it all up?
Yeah, well, I mean, listen, I'm on the back nine now, so almost 60, which is kind of shocking to say. But, listen, I think for me, as we talked about, I work out a lot, like if not every day, 6 days a week, 5 days at a minimum. Not because, I'm a little obsessive about it, but for two reasons. I want to be able to move as I get older, because medicine is very much a delayed gratification pathway. So that's the main thing. Number two, I want to be around for my kids, quite frankly, to sort of see them and see what they're doing. But the one thing I had not anticipated, which is very clear to me, is you're credible as a sports medicine doctor. Like, how old is this guy? Oh my God, maybe he's onto something. So that helps my personal sort of like messaging to patients. They really do, as you mentioned earlier, buy in. So by the end, I say this to my trainees, and this is where I am now. So at the beginning, you don't know what you want to do. You decide you want to become a surgeon. And then the big thing is like, am I going to get to be a surgeon? And then you go to med school and you do all this stuff and you match in the surgery. And then you go to train and you're like, can I do the surgery? Right? And then you train and you come out and then you're scared when you start and you realize, oh, no one's dying. I'm doing surgeries. It's actually kind of working. And then you get into some nuances, which is like, okay, can I get really good at this surgery? Can I become a master surgeon? Can I be someone that other people look to for information or to teach? And then there's some other nuances in there. Can I do the surgery efficiently, quickly? Because quite frankly, quicker surgery means less complications typically. So there's that. For me now, it's really centers around touching people's lives and trying to enjoy the positives. So what I mean by that is, 10 years ago, I would say, I spend 85% of the time worrying about 5% of the patients, right? And I still worry about them, and that's clear. Except I don't have the same angina about it, because I realize you're not going to get 100%. I'm probably at 94.5% good, right? So I can manage the 5, and that doesn't have a negative effect on me. I am 100% dialed in on that 5. But I don't have the angst and angina around it that I used to have, only because I really, really helped a whole lot of people. So, the only thing about surgery is very much one-to-one. It's one person and it's one outcome. It's one person. So one of the things I've tried to do in some of the innovation I've been involved with is to try to scale that. So we didn't really talk about it, but I have this implant that I developed with some partners of mine, and I think that'll have a big positive impact for exactly what you're talking about, like people who have early arthritis who maybe were looking at a certain kind of negative pathway, maybe having a bridging procedure that allow them to play tennis, to play pickleball, to run, to do these sports, because we're in an era now where physical activity is basically conjoined at the hip with longevity and
Yep.
and quality of life. So everyone comes in with that same angst, whether they're 17 or 77, it's the same energy. So you need to be able to meet them with that energy and be credible and be like, yeah, I get it. Look at me. I know what you're trying to do. Man, I'm just trying to keep doing a good job for people. It'll be over one day. And
Yeah.
It's fine. I think, listen, I've done a lot of stuff, which is great. I think, I'm super pleased to have been part of some of the innovative things. My biggest thing is, honestly, not to go off time, is my kid. Like, I don't really care. The medicine is great. I have great kids. My daughter, my oldest daughter, is going to medical school next year, which I'm just super excited about. So for me, that's where it sort of centers. Like when I'm on the way out, they're like, yeah, he did a lot of good work and touched a lot of people. That's just the nature of medicine. It does end at some point. So you just want to have just leave a good legacy.
Okay. I want to leave it off with one question is, looking back in your career and your life overall, what was probably the biggest challenge that you have faced that if you can go back in time, you'll say, I'll go through that over and over again just because it's made me who I am today?
Oh, we talked about it. It's Yale.
Okay.
Without question. Natty, I'm just telling you, it was awful. It was terrible. I mean, and any of my Yale classmates who kind of went through it with me, they would chuckle because what they saw was someone who, it wasn't like I was walking around with a puss face and I was unhappy, whatever. But the internal dialogue was like, man, can I do this? This is crazy. And I won't get into it. It's just a lot of crazy stuff that happened. I just want to remind people, I was in college in 1983. They didn't let people of color, women in until 1970. So when I got there, it wasn't like this 180-year-old institution knew exactly what to do with Black people. So it was a challenge, but it wasn't like at any point I was like, oh, I got to get out of here. I was like, you've got to finish this. So by the time I finished that, and to come out of there with the degrees that I had, with the letters that I had, it's really amazing. And by the way, I give to Yale and I'm on the board at Yale. I mean, like I love Yale. In real time, it was a really difficult time. But by the time I got to medical school, it was never any question. It was like, oh, it's like, yeah, look, I can do this. It's no problem. So, that would be a tough one to sign up for again, just because I didn't have a proper winter coat. But I don't. Yeah, I think anybody who knows me that was the time when the sausage was made. That's when it all kind of came together.
Okay. Now, what is the one thing that people who are listening to this, could take away when it comes to Ryder William as a person? Like, what would you like to leave to them?
I think I'll break it out into three parts. You and I talked about it. To do what we do, you have to have a high degree of intellectual curiosity and be an eternal student. I think that folds in being humble and circumspect and to be paying attention. Because the minute you start thinking you know it, then you make a mistake. But the derivative of that is don't get super caught up in your own largesse of what you think. Because again, it does end at some point. and the last thing I'll say is I have a great family. Like I've been married 31 years. Great wife, was a physician as well. That was the Yale and the Stanford and all that was undoubtedly the best decision, just because to have a partner who allowed you some gravitas and the ability to sort of think and to not be kind of caught up in the weeds was very much empowering. And my kids, like I have good kids, like they're great human beings and people, and that to me, when it comes down to it, as I'm looking up at the ceiling about to check out, that's what I'm thinking. Like I did a good job and was able to provide for my family in all the ways, while at the same time helping a bunch of other families. And that's honestly pretty cool.
Awesome. Dr. Williams, thank you so much for your time. I really appreciate this. It's been fun for me getting to know you. And then I know the listener, the future patient that listens to this, it's gonna be super excited just to join your cult.
I've never thought of it that way, but maybe we'll incorporate that in you. Thanks, man.
Of course. Thank you so much.